Wanted to take a quick minute to go over this again. I think I have figured out, and I want to make sure that you're just focusing on the screen and able to hear me. So I wanted to give a quick recap, and I've sort of re-edited the slides a little bit to add in maybe a little bit of a better flow for you all of how this information should flow together in terms of kind of where we were leaving off between the chronic and acute. Okay, so we had said, right, that when we look over pain modulation, we know that internally we have endogenous modulators, our neuropeptides, and our endorphins, right? You would think that by now I would probably have fixed this. So let's do that right now before. Sorry, guys, let's just do that right now. Okay, so there are our endogenous neuropeptides. These are the things that are modulating pain for us under normal conditions, right? And again, we had stated that it is very challenging for us to modulate pain because pain has many different components, even, right, this cortical recognition that there is an emotional state of pain. So that led us to this understanding that there's different pain components of which we try and utilize these opioids for treatment, right? And that variation, and as well as the body is trying to compensate. So we have two major components of pain as far as our distinct features. We said that we have first or early pain. Those first pain feelings or sensations are modulated by our A delta fibers. The reason that we feel those, again, very quick, very sharp, immediate sensation is because we have myelination. Just like our electrical cord is wrapped, it guarantees the signal goes from one end to the other and that we can receive that information from the extremity, from the point of pain sensation to the brain to be able to react to save the system, right? Burning fire, cut, right? And so again, we want that. That's a good thing. We want to know, should we react immediately? And myelination of those fibers is what creates a very fast response. Then we have this secondary or late pain, duller, more aching, burning, throbbing that we can feel for weeks after the site of injury because those myelinated fibers have shifted back, right? We're not utilizing those fibers anymore. We're waiting for should another major sensation of pain come in that we need to respond to, right? So think of our first pain as our first responders, right? These are our EMTs. These are our policemen. These are our firefighters. These are the people we're relying to show up instantaneously to address and save the problem, right? Address the situation for us. Then if we do go to the hospital, now we have the secondary. And when we go to the hospital, right, depending on what we're going to the hospital for, we have lots of different things that are coming in to take care of us, right? We have nurses, we have staff that's changing out the bed sheets, we have medical transcribers, we have pharmacists, we have different physicians depending on how many sites of injury or types of surgery that we've had, right? So we have this sort of larger sphere, right, of individuals coming to treat us. We're not getting that emergency EMT ride, right? We're not in the ambulance anymore where they're just trying to address the problem, get us out, and go back out and address the next problem. These are our C fibers. They are not myelinated. And again, another indication of why we know that this has this sort of secondary component of aching and burning, sort of diffuse pain, is because, again, it is not myelinated. So myelination helps us to get the signal from one end to the end very fast. For this, we are allowing for that diffusion of pain, the diffusion of via the immune response, right? Because really that's what we're activating here, to be more widespread, not so streamlined. It's not hyper localized under one, right? We can lose our signal all along the way. So again, just a kind of another follow-up of that. And so what we're doing here is we are trying to mimic, when we give drugs, what our endogenous opioids are doing for us, right? We're trying to integrate opioids and drugs into the system to modulate between the acute and the throbbing, right? And so again, even on that EMT ride, if you are in some serious critical danger because you are thrashing around because you're in such violent pain, right? They are trained to be able to give you injections or things right there on site so that they can stabilize you, right? Mainly, it's going to be a form of a sedative mixed with an analgesic so that you aren't causing any further injury to yourself or to those in the EMT ride, right? And so what we're doing when we're giving these acute treatments or treatments for long-term recovery pain, we are trying to integrate into the two major pathways of where our normal endogenous components, our neuroligands or neuropeptides, are already doing the job. So the first is we are trying to release more endorphins, and we are trying to, we are either trying to inhibit signals to the brain or signals back out to the body, right? So inhibitory spinal interneurons release endorphins by inhibiting the activation of spinal projection neurons to the brain. And we are also inhibiting descending modulatory pathways by inhibiting the projection neurons or the excitatory interneurons, or excite the inhibitory opioid neurons to be able to modify the pain signaling pathways to ensure that we are shutting off the correct systems, right? We don't want to shut off all pain to the body. And so again, that's why when we talk about dosing, we're looking at these things, especially when we're talking about drugs and therapeutics, under pharmaceutical and medical watch. You do have somebody coming in to monitor. You do get a pain assessment scale, right? When even if you're in recovery after a surgery, you're getting pain modulation and you're able to hopefully vocalize that if you are in pain or not. But then the nurse is going to ask you, give me a number, right? On that scale, 1 to 10. Where are you at? Then they're also going to assess when was the last time you got dosage, what is your body weight, all of that. They're going to look at all of those things to determine the correct dosage so that should there become a secondary pain response as an output of that surgery, infection, something else, so that they can modulate that appropriately, right? And so, again, looking at this, we are either inhibiting pain going to the brain or we are inhibiting pain coming out of the brain. And so our opioid drugs can interject themselves and affect, right, the inhibition of projection neurons, the inhibition of an excitatory interneuron that may also want to fire to send that signaling up. Or again, excitation, we want to stimulate an inhibitory opioid interneuron, one that would release endorphins to the system, to say, go ahead and modulate the pain downstream. So looking at this then, where we had left off and where I started to make modifications now, is what are we actually doing? How are we affecting these receptors? So again, we had stated 4 major subtypes. The major one I would want you to be focused on is the mu receptor. And again, it is mainly categorized and classified due to its being a morphine detector. And again, everything that we are looking at, just for comparative analysis, we are looking at G protein coupled receptors. But remember, this G protein slow metabotropic receptor, also as part of the activation pathway of many things that it can do, can also activate some of our ion channels, right? It can also be a downstream effect by activating some of our ion channels. And again, what is the main goal of our endogenous opioids or neuropeptides, or the taking of a drug that is going to mimic what our endogenous neuropeptides do? What we are doing is we are leading to a road of inhibition. We don't want the next cell to fire. And again, that goes back to, I either don't want to fire my next cell to send that pain signal to the brain, or I don't want the next cell to fire in a local extremity, right? Maybe my thoracic lumbar neurons that lead out into the periphery system of the lower lumbar or the legs where my site of injury is. I don't want them to send the pain signal down to the leg for where I've got the pain coming in. So 4 major ways, and absolutely we need to know this. Once I activate my G protein metabotropic, slow moving machine of my endogenous opioid mu, or one of the 4 major subtypes of receptors, I'm going to inhibit by opening calcium channels on the next cell, that would want to normally fire, which would say pain, either up to brain or out to limb. I'm going to hyperpolarize it by opening potassium channels. I'm going to say, don't fire, inhibition. I'm going to close calcium channels on a neighboring neuron so that it can no longer release and excite the next neuron. And inhibition. I'm going to activate an autoreceptor, a self-receptor, to no longer fire and excite the next cell, and inhibition. Or I am going to collectively throughout any one of these mechanisms also be, if I do activate, right, the opioid receptor on the postsynaptic cell, one of my other downstream effects is to inhibit adenylyl cyclase, which is going to lead a reduction of cyclic AMP, and that will decrease the feeling of pain. Cyclic AMP and adenylyl cyclase makes cyclic AMP. Cyclic AMP is an important part of the pathway, another mechanism by which we can feel pain. So again, it was asked in class, what if we don't feel pain? How do we There's lots of ways, right? There's a lot going on here. There's a lot of places that the body can utilize the activation if one thing gets out of alignment to be able to still stop the pain signaling. Remember, the end goal of all of this is keep you alive, right? So again, this is just the imagery to support the prior kind of explanation of the words. But keep in mind that these are the 4 mechanisms, but the 4 mechanisms of action, they could all be happening simultaneously. They could be happening one individually at a time. But all of these 4 things are meant to stop by inhibiting the next cell from firing. So keep that in mind. Okay, so now let's move to the last big concept that we were trying to cover, the chronic opioid effects. So at tolerance, right? We know that we are in tolerance, we need to up our dosage, right? Once we hit tolerance, we got to go higher. We got to go higher. Then we move from the liking to the wanting. Now we're in the dependent state. Now I start to see that my central nervous system is going to adapt to this, and it's going to go through severe pain withdrawal, or severe withdrawal by exacerbating the feeling of pain. And I've got pictures to show this in just a second, when I do not take the opioid. Then when I go through the withdrawal symptoms, my system, my biology still is under the, right? If I've taken yesterday and tomorrow I'm quitting, and now for the next 30, 50 days, I'm going through 60 days, I'm going through a detox program. That first 30 days, that first week, right? My body still has to acclimate and come back down to pre-tolerance levels. So now I don't have the drug and my body is compensated. So now I'm going to feel hyper pain, right? So these are the words, and then I've got pictures. Initially, what we see is that what opioids again are doing in that picture that we walked through. We are inhibiting, right? As one of those 4 mechanisms of inhibition, we are inhibiting adenylyl cyclase, which leads to a reduction of cyclic AMP, which says, I don't feel pain. When we start to move towards hitting tolerance and dependence, the body is now saying, something's wrong. Do something about it. So what we see is that other mechanisms start to compensate for the reduction of adenylyl cyclase and cyclic AMP, and they start to return those back to quote unquote normal levels. Then what happens? I decide to quit tomorrow. Boom, I've cut off the drug. And now the system says, okay, I don't have that thing that I was in competition with to downregulate cyclic AMP, and I've already been working at a lower level of adenylyl cyclase that leads to cyclic AMP. All systems go, open the floodgates. And now it massively ramps up cyclic AMP, and boy, does that cause pain, because now you're feeling it tenfold, right? So again, I've got pictures to show this. So in the acute phase, right, my opioids are going to bind. In this case, we're looking at fentanyl, right? Or we could even be looking at, any version of of an opioid. But what are we doing? We're binding our receptor. We're activating our G protein coupled receptor. And again, series of different mechanisms. I can open up potassium channels and hyperpolarize my postsynaptic cell and inhibition, right? I can turn off calcium excitation and inhibition because no longer the presynaptic cell firing. But inevitably, the long-term downstream effect is, right? If I'm doing this, what am I doing? I am turning off adenylyl cyclase, and adenylyl cyclase is going to lead to a reduction of cyclic AMP, and I'm going to no longer feel pain. So again, opioids bind, leading to inhibition, one of the 4 mechanisms we covered in slide 23. I inactivate adenylyl cyclase, no cyclic AMP, no cyclic AMP, no pain. So drug's doing its job. But now what happens when we move to a tolerance, addictive, wanting, dependent state? The system is going to say, this is no longer sustainable. I can't not feel pain. So it starts to remove these receptors out of the postsynaptic membrane, right? As it is doing that, right, less opioid receptors are available as the cell has pulled them in to reduce the activation of these. And that also sends a signal to the nucleus to say, don't even print any more of these proteins. I don't want any more of these receptors. I've got to start compensating so I can feel pain again. Additionally, what this does is it turns other systems on inside the cell, because there's lots of systems inside the cell that can activate adenylyl cyclase and cyclic AMP, and they start to compensate, right? They're starting to try and bring things back up to the pre-tolerance level. They're just trying to bring you back up to baseline. So now what happens? It's a push-pull state. You're taking more opioids because the body's trying to compensate by raising cyclic AMP. You feel pain, you got to take more opioids. It's just a cat chasing its own tail, right? Now we're ready to go through recovery. We're ready to go through withdrawal. Well, the body will, from one day to the next, the body's just going off of what you're giving it as far as stimulus and information. So even though you've removed the drug, and maybe we start to compensate, maybe those opioid receptors that were still there are now maybe slowly being activated by some of our endogenous neuropeptides, but the system needs time, right? Depending on how long you've been taking those drugs, the system needs just as much time to recover to get back to baseline again. It's not sure, are you going to Is today no drugs, tomorrow more drugs? It's in real time adaptation. So there are still less opioid receptors that are available. And now the cell's saying, oh, I don't have that other thing I'm trying to compete with. And I've not been able to run at the appropriate adenyl cyclase and cyclic AMP levels. All systems go. Open the floodgates, let cyclic AMP ride. We need it, right? Because remember, we are still printing and trying to reinsert new receptors back into the membrane. So as it's building back up to normal levels again, it's overcompensating by using other mechanisms to really kick up cyclic AMP. And now what happens? Now you massively feel pain because you're no longer taking the drug. So even those receptors that were around can't even be activated anymore. And the system says, I don't know what's going on here, but let's figure it out real fast. If they're not doing this, I'm gonna try and compensate in real time right now. And hyper pain, hyperglycemia. Now you have massive pain awareness, and this is where people go back into relapse. So again, this would be sort of the explanations transition states that I would be looking for. Same things that we talked about with alcohol too. And again, just another way to look at this. So the very last little bits were, again, how do we look at this stuff? Well, we have to look at, again, the biopsychosocial models. What are your triggers? Where were you at? Are you in a new environment? Do you have a lower tolerance to this? Are you in a risk of overdosing because you're going back into your triggers? You're going back into your environmental cues, right? And as we've mentioned, we have to take the biopsychosocial model of approach, biological, psychological, and environmental. We stated that there are lots of different uses that we can use outside of the introduction of drugs. We can use gene therapy. We can utilize acupuncture to try and re-ramp up those endogenous opioids in the meantime to modulate pain locally. And we can even use things like electroacupuncture, where now we're actually sending a current. It stimulates even more. It's actually ramping up that pain modulation of response. Typically, what we would do, because of the excessive amount of pain, we typically will give individuals going through withdrawal methadone. This is a longer acting, lower dosage, not as strong partial agonist. But again, methadone, if we're not aware, methadone is also at risk for being an addictive thing because it is a step down of an opioid, but it's still an opioid, right? We have to walk you down, just like we talked about with individual, babies that come out. We have to wean them off of the opioids by giving them small doses until they can be in full-blown withdrawal. We would look at again, maintenance of methadone because again, it does have some problems associated with it. We have to be able to maintenance this. We have to look at this as we are going through the withdrawals. But this is definitely something we are turning to as a first, especially when it comes to individuals addicted to heroin. Because again, the bioavailability, the ability to get into the system via that route of administration and pass across that blood-brain barrier, heroin is extremely addictive, right? Finally, there are therapeutics that we are looking at for things like opioid vaccinations. This would prevent the drug entry of things like heroin or those even smaller amounts of our morphine into the brain. It's currently in more of an experimental design phase, but it is something we are looking into, right? We're also looking at, a combination of different meds and behavioral therapy because these are the most proven as far as effectiveness, right? The biopsychosocial model is really, really important here. So I am also posting for you guys. I found two really cool videos. One is just a short overview and the other one kind of gets more into the specifics. Use them however you feel is necessary. They're just there as additional resources. And then finally, I hope you've seen that I've posted the overview guide. It is merely just a guide. At this point, you should not be relying on any of this other than maybe this video to help you bring update for acute to chronic for opioids. But at this point, you hopefully took last week to review your prior two chapters. Okay, that's it, guys. Make sure you come prepared, Scantron, pencil, all the good stuff, and I will see you in class for exam 3 tomorrow.